colleagues, and because we're running a little bit late, I have made the decision that we will actually just go straight ahead to Sharon. And Sharon, now we're moving into our pre-doctoral session, and in our pre-doctoral session, the DMRS, we always invite a couple of pre-docs to come and share their research with us, because it's very important for them to engage in this activity at this level. And our first speaker is Sharon Guille. I mentioned to you earlier on about Sharon. Now, Sharon was nearly a midwife, and we nearly lost her because she did 2 years of her midwifery training. But thank goodness she got the research hook and was caught by the researchers and started to do research, and is now in the final stages of her PhD research. I'm sorry for you midwives, sorry you didn't get her, but then you'll eventually get her, because her research is she's 100% committed to midwifery and to breastfeeding. And Sharon's original degree was in psychology. So Sharon's a lovely mum. And over to you, Sharon.
Thank you. I am waiting for, I think, my video to start, so I'm not sure. Okay, great. So thank you.
Good morning, everybody. It's lovely to be here today and to be part of this conference. My name is Sharon Guille, and I'm a PhD researcher at Ulster University. As you can see from the slide, the title of my research is exploring the experience, management and impact of nipple pain in breastfeeding mothers. In the short time I have with you today, I'm just going to talk briefly about some of the literature relevant to nipple pain, but mainly I'll be focusing on sharing some of the findings from one of my study stages. So in terms of providing some background, which I'm sure you're familiar with, nipple pain is given as a common reason for stopping breastfeeding, but I think it's equally important to note that there are many mothers who will continue to breastfeed despite experiencing pain. The incidence of pain varies in literature, but data from the last UK Infant Feeding Survey in 2010 reported 62% of mothers experienced breast or nipple pain sometime during their baby's first year. In terms of how long the pain's lasting, some literature suggests a reduction between day 7 and day 10. However, other research reports 20% of mothers continue to experience nipple pain at 8 weeks postpartum. According to the Academy of Breastfeeding Medicine, any pain lasting longer than the first 2 weeks is classed as persistent pain, and this is differentiated from pain which may be seen as common in the first few weeks of breastfeeding. NICE Clinical Knowledge Summaries provides information on the current evidence base and practical guidance for breastfeeding problems. Causes and management for nipple pain can be seen in the slide, and it's important to note that there can be more than one cause for nipple pain at any given time, which in turn has implications for how it's managed or treated. There are also numerous other interventions, including non-pharmacological and alternative therapies, but the evidence for their use is limited. Previous systematic reviews looking at the prevention and treatment of nipple pain from Merlin, Schultz and Hill in 2005, and more recently Dennis et al. In 2014, concluded that as there was no recommended intervention to treat nipple pain, both reviews refer to the importance of considering position attachment for decreasing or preventing nipple pain and trauma. The earlier review in 2005 included 2 papers concerning position attachment education. However, it wasn't included in the more recent review in 2014. So this really led to the first stage of my study, which involved conducting a systematic review with the aim of collating and synthesising the current evidence for the effectiveness of position attachment interventions for the prevention and or management of nipple pain in breastfeeding mothers. Other outcomes included identifying factors associated with effective intervention design, and finally also looking at the effectiveness of these interventions in breastfeeding duration. The systematic review was published just in September past, and the findings from it will really be the focus of this talk today. So as you can see from the slide, the PICOS tool was used to develop a search strategy. The population of breastfeeding dads included primoparous or multiparous mothers who participated in experimental studies examining the effectiveness of position attachment interventions for the primary outcome of nipple pain, and then breastfeeding duration was a secondary outcome. The interventions in these studies could be delivered using a variety of methods, mediums, settings, group sizes, and they could be delivered by a professional or a lay person at any point during the antenatal or postnatal period. The interventions didn't include position attachment as part of what might have been a wider breastfeeding educational programme. So the search terms for the review were derived from the literature and from PHA information from Off to a Good Start, which is given to mums, as well as the NICE guidelines that have already been discussed. So following the database search and having removed duplicates, 163 records were screened by title and abstract. 152 of these were excluded, which left 11 full-text articles which I assessed for eligibility, and 3 of these studies met the full inclusion criteria. The 3 included studies consisted of 2 randomised controlled trials and 1 non-randomised study involving 489 mums from 3 different countries at 3 different time points. In terms of the primary outcome of nipple pain and the secondary outcome of breastfeeding duration, in the first study, a single postnatal position attachment counselling session didn't significantly reduce the incidence of nipple pain or increase the rate of exclusive breastfeeding at day 7 or day 30 postpartum. However, the second study in 2017 did result in a single postnatal demonstration-based training session which significantly reduced the incidence of nipple cracks compared to a group of mums who received a brochure or the group of mums who received routine care, and this was significant at 2 weeks and at 4 weeks postpartum, with a higher non-significant percentage of mothers exclusively breastfeeding. The third study in 2020 was the only intervention which included an antenatal and a postnatal part using a video, and then a postnatal biological nurturing approach to care, and this resulted in a significantly reduced risk of cracked and sore nipples at hospital discharge and at day 7. The finding was no longer significant at day 30, and although the percentage of mothers exclusively breastfeeding in the experimental group was higher at all data collection time points, the finding wasn't significant. So overall, the applicability of the evidence from this review should be interpreted with caution due to the low number of studies, conflicting results and variations in the intervention design. So you can see from this next slide the difference between the studies, which in turn creates challenges in identifying factors associated with effective study design. 2 of the interventions were delivered on the day of postnatal hospital discharge, which might have actually been too late. Only 1 study, Malenko et al. In 2020, included an intervention that had both an antenatal and postnatal part. There was also differences in terms of who actually provided the intervention. So in this first study, in 2006, the intervention was delivered by 2 nurses, one who was also a lactation consultant. The 2017 study, the brochure group, was delivered by the researchers, and there's no information about their background and also no detail about who actually delivered the demonstration-based intervention. And in Malenko et al. 2020 study, all staff who normally looked after mothers provided care for both study groups, and this was also the only study that reported that staff actually received training prior to intervention delivery. In terms of the mediums used, the 2 demonstration-based interventions, which is the 2006 and 2017 study, both used puppets, dolls, pictures and model breasts, and both studies reported different results in terms of the significant effect of the intervention on nipple pain and breastfeeding technique. Therefore, it also might be important to consider the effectiveness of the trainer in delivering these interventions. All experimental interventions were delivered face-to-face with limited information on the group sizes. So in the 2006 study, the intervention was delivered in groups of no more than 2 mother-infant pairs. No information on group sizes was provided for the second study, and the more recent 2020 study involved all staff normally involved in maternity ward activities providing support, which presumably would have included one-to-one care as part of general postnatal care. And finally, with regards to intervention duration and frequency. The two demonstration-based interventions occurred at one single time point, with one lasting 30 minutes and the other lasting 1 hour, whereas the biological nurturing approach consisted of care that lasted the duration of the mother's postnatal hospital stay. So this would give increased opportunities for the intervention to actually be reinforced. Only one study provided mothers with a brochure which included written and illustrated information, and only one study provided mothers with a video to watch in the antenatal period, which in turn may help them prepare for the intervention and indeed breastfeeding itself. So in terms of the completeness of the evidence, all three studies in this review assess the effectiveness of position attachment interventions on the incidence of nipple pain only. None of the studies used any tools to measure nipple pain severity, nor did they gather any other information such as the causes of pain. No study set pain as an inclusion criteria, and only one study assessed the incidence of pain before intervention delivery. A more thorough pain assessment before and after would enable more rigorous testing of intervention effectiveness. In the first study by De Oliveira et al. In 2006, they reported that breastfeeding problems were similar in both their study groups, and they suggest this results in agreement with the fact that their intervention did an improved technique, which was assessed before and after intervention delivery. In the second study, they reported a significant increase in latch scores and a significant reduction in nipple cracks. And it wasn't clear in the 2020 study if they measured breastfeeding technique, although the authors suggest that their significant results may be explained by a higher portion of successful latching in the experimental group. So again, similar to assessing nipple pain before and after intervention delivery, the assessment of position and attachment parameters at both time points would enable studies to assess if their intervention actually improves breastfeeding technique. And as nipple pain was prevalent during postnatal hospital stay in all three studies, it might be beneficial to prepare mothers for the possibility of this outcome during the antenatal period. In terms of breastfeeding duration, across the studies, exclusive breastfeeding rates ranged from 40 to 87%, and any breastfeeding ranged from 87 to 100%. Therefore, the effectiveness of any intervention on duration might be limited when the breastfeeding rates are already high. So in conclusion, previous systematic reviews advocate the potential of positional attachment interventions for nipple pain, identifying this as an area for further research, and this is really a finding that's shared in this current review. Further studies will also help identify factors associated with effective intervention design. Constraints in staff time are also well known, so interventions need to be realistic if they're to be delivered as intended. And also improving breastfeeding duration may be beyond the scope of a single intervention given the complexity of breastfeeding behaviour. And finally, it's important to note that when considering the causes and management of nipple pain, poor position attachment can be viewed as the cause, whilst optimal position attachment can be seen as a preventative measure or a management intervention. Although efforts can be made to improve mothers' knowledge about the prevention and management of nipple problems, breastfeeding as a practical skill, and research by Kent et al. In 2015 suggests that position attachment may need to be assessed more than once during the first few weeks, and advice on the correction of position attachment may need to be repeated. Other research suggests when breastfeeding supports are offered to mums, the duration of breastfeeding is increased. Therefore, an integrative approach of increasing knowledge and support may be more beneficial. So just to finish up today, in terms of other progress, my research includes 2 further stages consisting of an online survey and online focus groups to explore the experience, management and impact of nipple pain in greater depth. Ethical approval was obtained just over a year ago, and both these stages have now been completed. So I hope to return next year to share some of these findings with you. So that's me for today, and I'll try and answer any questions you might have. Thank you.
Oh, fabulous presentation, Sharon. Thank you very much. Perfect timing, 13 minutes. Wow. Sharon is live with us now, and I'm just, I've got one question here that we've time to answer. One question. This question has come in from Haley Carter. Sharon, Haley wants to know. She said she's made a statement here, which I'm just going to rephrase to you. So it would seem that an antenatal and a postnatal approach, plus having all the staff involved, works. Is that what you're saying? I think that's what she's asking. Is that what you're saying? Could you just chat a little bit about that, please?
Yeah, well, sorry, I think it was the more recent study in 2020 that had their intervention for position attachment had an antenatal and a postnatal part, and it was the only study from the systematic review. The rest of them were postnatal interventions only. So I think in terms of the findings for that result, they actually found that having both was good for the prevention of nipple pain. And I think in terms generally it would work well, because I think there's an element that mums need to be prepared antenatally for breastfeeding. But again, it's one of those things that if it's your first baby, you don't really know what to expect. So there's only so much preparation that you can have, and maybe a combination of approaches of antenatal and postnatal might work well. And in that study as well, it wasn't just say midwives or lactation consultants, it was all staff involved in maternity care that delivered the intervention. When you look at like the constraints in staff time, I think it makes sense, and it would be good that if every staff member, because there's so many staff involved in postnatal care that could help out, and when you look at burdens in staff time and the many people that are interacting with the mother in postnatal ward, it would be helpful, I think. So no, it was a good study. That one.
That's very helpful.
There was more research in that.
Thank you very much, Sharon. Sorry, I didn't catch that last bit.
No, I'm just saying it would be good if there was more like studies in that area that had a combination of antenatal and postnatal. And as I say, when you look at, there's peer support, there's breastfeeding support, there's maternity support workers, there's midwives, there's lactation consultants, all involved in postnatal care. So if it's an approach that isn't just focused on one profession helping a mum, but everybody can help. When you look at like staff time and the many interactions a mother could have with different staff members in one day, I think it would work well.
Thank you. I'd love to ask you loads of questions myself, but I can't. I can't. Thank you very much, Sharon.